Hello.
Good
Hello,
morning.
Dr. Ben. Good morning. How are you doing?
Okay, hey Nora, I'd like you to put a background of neurosurgical TV if you can.
Oh, I think it's a little difficult for me because of my lightings. I think that there's an ample lighting. I've been trying to change the background myself into a virtual one. But how
Okay,
do you have
let
it?
me send you
Yeah.
so you can put it in your background. Okay, because this is a televising for neurosurgical TV.
Yeah.
Unless you want to pay, of course, Nora. You can pay and you can put any background you want.
What?
Okay, hold on.
It's another WFNS event. I'm so happy that we are like people are like thinking that the neurosurgical
Did you
TV
see
is
did you see last night? Did you see
the Chinese one. Yeah, I
oh,
just
you didn't see China, right? You didn't see China.
yeah, yeah. I was on call because I had to be to take an off
Oh,
today.
that's right. You're
Yeah,
on
so
call.
I'm an on and off today because it's very hard to be online on a work day.
Well, okay, I'm gonna send you this and
That people have a lot of
you
time
know how to
right
put it
now,
on the background, right?
and yeah, exactly. And people are like expecting all the time that we are
Okay, there you go. I'll be right back, okay? You get,
sure.
yeah, there is a, I've been having problems. Okay, I sent you the, let's see, did you get it?
Yeah, I'm just trying to open it now. Will you make me a co-host so that I can let people in the meantime? If
Okay, put it on your background, please.
oh
Did you get it? Okay.
yeah, I'm trying. To.
Okay.
But usually I have a lot of problem with the lighting. I think that do you have the
A license, this is my license, okay? You need this to get on the webcast. You need the background. It's my license.
Let me check if I can. No, lighting. I'm saying the lighting. I have a lot of lighting behind me, so let me check if I can. Okay. Do you use green screen? or you use it without a green screen?
My central background with neurosurgical TV. You know how to put it on, right? You go
Yeah,
to the
I'm
videos,
trying
you
to.
go to the video, open it up, and then choose virtual background. Do you see that?
No, I cannot load it in the first time. Can you send me in the chat?
Yeah, okay. Okay.
Let me share it with a few other people. He has, prepared the entire hospital for this. I guess
Okay,
it will.
bottom left. At the bottom left, go to the camera.
No, I mean the picture because I cannot load the picture from the messenger. Probably you have sent me on the
Okay, go
messenger.
to the camera on the Zoom platform at the bottom. You see it?
Just wait a second.
Open up the menu at the bottom at the camera. You see the camera?
Hold on.
Okay.
I'm actually trying to first load the picture that you have sent to
Do you
me.
see the camera?
This is amazing. Yeah, this is the camera, but I do not have the picture. Can you send me the picture? The background. I mean the virtual background in the chat.
Okay, did you open the camera menu? It's next to the icon. There's a little arrow. Open up the menu for the. Oh, she could now. Okay, and then you go to the choose virtual background. Did you choose the virtual background? You got that? And you pick your picture that I sent. Okay, go to the virtual background. You got that? Are you at the virtual background now? You got to put the plus mark to add it. Do you see that? Nor? Do you see the arrow? Do you see the, are you at the menu now to open it? Oh, okay. No, that's okay, okay, I'll wait until you get it. Go to the camera at the bottom left. Are you there at the camera at the bottom left? Are you there, Nor? Hello, Nor? It'll work. We'll get it. We got a half hour. We'll get it. Okay, go to the camera. Are you at the camera now? Nor, are you at the camera? You click on the menu sign next to it. Okay, keep working, okay, Nor? I'll be back. Well, okay, Nora, if you can't figure it out, forget it. We'll do it some other time. Nora? Hello, Nora?
Hello? Can you
Yeah,
hear?
yeah, we'll
Can
do
you?
it some other time. You can,
Yeah. Okay. Please make me the co-host now, because I will have
yeah,
to look
okay,
for the attendees and
okay.
etc. Yes. And tell me, how do you put that
Hold
virtual
on, Nora,
background? Because yeah,
hold on,
yeah, yeah,
hold on.
yeah. I'm trying my best, but
Make,
I'm
make, no, don't do it, we'll do it later. Do it later.
yeah. I don't know, but it's why not? It's working for me. I think it is because of the lightings. How do you make it happen? Because whenever I put it on, it's all over my face.
Okay,
It's
okay, now
yes,
listen to me, Nora.
yes.
Are you at the bottom? You see the bottom, there's do you have a desktop or what do you have, Apple?
No. I have my Windows phone, Windows laptop.
Do you have a desktop?
No,
A
I have this laptop.
laptop?
Yes, laptop.
Okay, at the bottom left, there's a sign of a microphone and a camera. Do you see
Yeah,
that?
yeah. No. I do try it, but
Okay,
see,
okay, now
let's check it.
listen to
Yeah,
me,
yeah,
listen to me.
yes, yes.
Now, next to the camera, there's a menu. Okay, open up the menu. Do you see the
Yes,
menu?
and the virtual background. I know that.
Okay,
The
choose
yeah,
virtual background.
yeah.
Okay,
Let
now
me.
go,
Yeah.
there's a plus mark on the far right above the pictures. You see, it's an add image or video. You see the
Yeah,
plus
look.
mark?
Yeah,
Okay, click
yeah,
on the
yeah,
plus
that's
mark and then you can pick on your computer where you go.
and that's what happens. See?
Okay, click on the plus mark and then look on your
Yeah,
computer for the image I sent you.
let me check, but it doesn't seem to be. Wait.
You can do it. That's okay, no.
No, I'm just trying my best if I
No,
can do it
do
because
it after.
I was
We'll
I
do
was
it after. We'll do it after.
I was also required to do it in the double ANS, but I couldn't put it up. So whenever I
Well,
do, yes,
Nora, you're gonna
yes.
be a conference person, so you gotta learn how to do it in the future. We'll
No,
just learn in the future.
it doesn't work for me. It doesn't work for me. I don't know why.
Okay.
Yeah, but I think it is the lighting
Okay,
that's the
just
issue.
figure it out. Figure it out later, okay?
Okay.
You'll
Yeah,
you'll get it.
yeah. I'll be checking. Let's see.
Yeah, just
Okay.
there's a video about it, I'm sure, how to do it.
Yeah, no, I can know. I do know how to do it, but it is not. It is not getting superimposed. Whenever I put it up, it comes over all over my own face.
Okay, Nora, you
So
have the
yeah,
speakers lined up? Do you have the speakers lined up? They know about it and everything, right?
yeah, exactly. He's
Yeah.
coming in.
Okay. Yeah, the links break.
Yeah, I think
Yeah,
this
when
is
you
because
copy and paste them. And I put so many links on the internet, you know, there's some get bad, some get what's called degraded. You'll put
yeah,
it
I know.
normal,
Yes.
but then you'll copy it and it'll degrade. The Zoom link will degrade. So
Yeah, yeah,
that's why I make two links.
yeah. I
I
think
have
this.
to help hopefully prevent that.
Yeah, exactly. But no, it's not an issue. Just I updated it, so it's okay. We manage it. If you just noticing it in time, then you can just simply manage
Yeah,
it. So
what'd you
it's
think of it?
okay.
Okay, did you see? Oh, you didn't see the webcast. Yeah, we
Oh
had
yeah, I missed
Barbara
it.
came. Barbara came.
Wonderful.
Yuha was there.
Look,
Um,
amazing. And
yeah, Atul came. I asked Atul to come. He was really nice.
yeah,
They're all nice.
I will look. I will go through the recordings. Unfortunately, I
No,
couldn't be there.
I didn't want to overwhelm the
Yeah,
Chinese with
Yeah.
my ideas. You know, unlike you, I have a lot of ideas, you know,
Yes.
and I want to
But
tell them about
once,
them, but it's better I just lay back. Okay, I'll
yeah,
be back, Nora. I'll be back. Okay.
sure, sure. Thank you. I'm there. I'm just
Okay. Okay.
making sure everyone is.
I'm sure you have something to do.
Yeah, I'm working on it.
You know, Nora, that link is working for me now. It's so strange.
Really?
Yeah, both are working now.
That's good then. I'm also trying to promote it on the internet, because you know, if people have most of the time, what I have noticed is that people do have a lot of time zone confusions. So I'm just trying to um, update that we are online now, so maybe people have a little less confusion. I don't know, but still people are having the basically, I think because we are all in different time zones. So
Yeah, sometimes the link
yeah.
works. That's why I give two, because sometimes that link will work, sometimes it doesn't. It's crazy. It's
Yeah,
crazy.
yeah, it happens. You know, it's kind of funny, but you know, it happened with a
I was
speaker
very
once.
careful about it because I made that mistake in the past. And I said, well, I better put two links in. That's why I put or.
Yeah, but I had the previous link as well, so it worked for me. Since I had the previous link you have sent to me, so it was quite good for me to be there. I, and that one is much working.
Yeah, but you better check with the speakers to make sure they know they got it.
Yeah.
Okay.
Yes, yes, exactly. I'm just sending the same link from which I have logged in myself to them as well. But I think there are some, since there is a lot of overwhelming on the Zoom network, I think there is some little glitches that are now present in Zoom, which were never there before. It is, I think, because of a lot of
Hi, Zainab. How you doing?
Good
Here's-
morning.
Good morning. How you doing?
Hi, sir. Hi, sir. Thank you so much, sir, for coming, sir. Professor Ahmad Alhani has just logged in.
Okay, Ahmed's here, the Nourish. You know that.
Hi,
right?
sir.
Okay.
Welcome, sir.
Good morning, everyone.
Good morning.
Can you hear me now?
Yes,
Yes.
sir.
Very good. Okay, now you can see me, I guess.
Yes, sir. We can. Thank you so much, sir.
Okay, let me adjust my seat. Let me adjust my laptop. Does that looks good?
Yes, sir. Exactly, sir.
Okay. Why is that light not very well?
Well,
Thank you so much, sir. Yes, we can see and hear you.
well, you know, Noah, I like it. He's concerned about his picture. That's unusual.
Yeah, and it's very important too because people are more trying to have a better look.
We have an issue with the light, don't we?
Yeah, let me get,
lights.
okay, I'll put you on the main screen there. Yeah, you got some kind of ray of light coming in. There you go.
Yes, I think the top them.
Let me see if this is better now.
Yes,
Yeah,
sir.
that's
There's-
good. That's good. See, look at I'm Dr. Bennett, Ahmed. How you doing?
Very well, very well.
Okay,
Good
look
morning,
at my
Dr.
look at my background. See, I'm changing my light now. See that?
How can you do that though?
Well, I'm just moving my lamp.
Okay.
Yeah, I have a lamp, so I move it like that.
Okay.
You know, so there is a.
I
you
don't
can-
have. Shall I
No, it's
have?
okay. You look good. Now it's perfect. Now it's
It's perfect,
perfect.
sir.
Let me
Perfect.
try something. Let me try something.
No, it's perfect. It's totally perfect. So I don't think that you have to do it.
Is that
Yes.
by any mean better?
That's
Yes,
good.
everything
That's
is good. Perfect, sir. Perfect. It's totally
Good.
perfect. Thank you so much, sir.
You're welcome.
Sir,
that
thank you so
better?
much. It's a matter of huge honor to have you here today with us.
I'm not sure if this is better or not. Yes, better.
Yes, it's good. It's good. Very best.
Yeah, I just changed my background.
Good. So let me see my eyeglasses now. We go to the eyeglasses issue.
Yes, sir.
So I can see. Okay. I like that.
Thank you, sir. Thank you so much,
You're-
sir. Yes. Thank you so much, sir. Sir, I'm really overwhelmed to have you here. So it's a matter of huge honor and pleasure to have you, sir. Thank you so much for accepting our invitation. It's a very important topic, and I do think that I know you from several different references, and I'm just convinced that, mashallah, you have a lot of competency in this very particular area of DBS for Parkinson's disease. And you are the chairman of the Functional and Stereotactic Surgery of the WFNS committee. So it's a matter of huge honor to have you here today with us. I'm also messaging Professor Asif Bashir. He's also one of my own mentors. So he's one of those few people who are doing the DBS surgery in Pakistan right now. It's him and also Professor Khalid Mahmood from PINS, from where I belong, from where I have completed my own training. So we do not have much of this service. Whenever we had the DBS case, it was quite a huge thing, and we were all quite lined up in the operating theater to have a look on how it is being done. So we haven't got a lot of DBS surgery right now in Pakistan. There we have got the third lecture on fiber-based tracking system for the DBS surgery for Parkinson's disease. He's also got a good case on robotic DBS, and we were quite intrigued that it is something that of the future. So.
Noor, can I try to share my screen to see if the PowerPoint is working?
Yes, sir, please do, sir.
So what should I do? Click on share screen?
Yes, sir. Yes, sir.
Okay, so I did.
Yes, sir. So, it's active. So from where you will see that your PPT, yeah, exactly. Yes, exactly, sir. So this is the webinar presentation. Just open it.
I am working on that. Okay. I have to handle this.
Yes, sir, sure, sir.
Okay, so let me put this on no sound, no vibration, complete mute. Okay, yes, and sir. Let me do like this.
Sir, have you opened your PowerPoint?
I opened it.
Yes, but we cannot actually see, sir. So you have to unshare the screen and share it again.
Okay, so yes. You are screen shared. Stop sharing. I did stop sharing. Okay, exactly. What should I do now? Go again?
Sir, yes, so share the screen again, and then you will see the PowerPoint presentation. You have to select that.
Okay, just give me a second so we are not late.
No, it's okay, sir. You are.
I'm just going to get rid of this. I'm just going to get rid of this. Okay, excellent. So let me close that. And let me go to share screen. And yes, go to here. And go to
the PowerPoint, sir.
Share. You can see now my
yes.
screen.
Yes, sir. We do. We can do. Sir, we can. So just put you have to click the
You,
forward
you see
button.
my arrow somewhere?
Yeah, sir. We can easily see.
Okay,
Yes,
very
sir.
good, very good. You
Thank
are
you, sir.
screen sharing now. Okay, that's very good.
Yes, sir.
Okay,
Sir, just
so
sir, if you click the forward button in your, you can do both. If you are easy with the mouse, you can scroll with the mouse. You can just go forward through the mouse, or you can go forward through the. Exactly, sir. Exactly, sir. We can see it. Thank you. It's
okay.
perfect. It's perfect, sir. This is an amazing topic. It is very important topic. Thank you so much, sir, for sharing this talk, because I do think that is one of the most important things that we have to discuss today.
Well, it's my pleasure, and I will keep the discussion at a sort of general neurosurgery interest, and
Yes, sir.
I will be stick to time, and
Sir,
I hope everything will be.
but if it is more comfortable, you can, we will be pleased to have you take your time if it is more comfortable to take a few more moments, because it's an important talk and it is also recorded. So many people who are not present right now, since it's a weekday, will be able to have the benefit of listening to you as in the form of a recording. Sir, I'm also working on a booklet. So if you on a book, if you really if you like, then I will be really honored to have you contributing in that book on Parkinson's disease surgery, if you really wish to do so.
It's my honor, Noor. It's my honor. It's my
Sir,
honor.
honor is all mine, sir. I do think I was really overwhelmed because I really wish to have your kind presence and your kind knowledge. It means a lot to us, especially to the young neurosurgeons like me and many others who are still in their learning phases, and who belong to our area where learning is, we do not have that much of opportunity of learning such wonderful surgeries, and the future of this neurosurgery obviously depends on several of these techniques. So it's a matter of, it's a huge achievement for us all to have you here. Dr. Anirban Deep Banerjee has just joined in. Dr. Anirban, I have promoted you to the panel. Can you see it?
Are we trying to get someone in?
Yes,
Okay, Momin Bashir. You're
yes,
trying to
Dr.
get in.
Anirban.
Okay, I'm trying to get in.
Yes, he's in now. Dr. Anirban. But we will just. Can you hear us, Dr. Anirban?
Hello, good afternoon, everyone. Am I audible?
Yes, you are audible.
I guess we're gonna leave the screen share on, Noor, or
Yes, many thanks for this opportunity, Dr. Noor, and it's an honor to be on the same platform with Dr. Alhani. It's a great honor to see him live. So I think
Noor, are you there? No, we haven't started yet. We haven't started. We started.
So we can start it right away, right? Yeah.
Yeah, we start in a few minutes. Noor, do you want him to share the screen now, or
Well,
Noor,
okay.
or just leave it there, or you want to?
No, I think I will share a very short presentation just for the sake of completion of our webinar. I will just share a very short presentation for formality basis. Just what's the time right now? Yeah, we are on time. Okay, we are on time. I was waiting for Professor Asif. I think I will have to.
Okay, we'll wait for somebody.
No. Yeah, no. He will join in, I think, in the middle.
Okay. You ready? You ready to start, Noor? You ready?
Yes, I'm ready to start.
Okay. Here we go, Noor. Here we go, Noor. 10,
yes, just
9, 8, 7, 6, 5. After I say 1, then you start. 5, 4, 3, 2, 1.
Good morning and good afternoon, good evening, wherever you really are. We are really honored and pleased to have this webinar on the World Parkinson's Day today that is celebrated every year on 11th of April. It has a lot of meaning for all those people who are suffering from Parkinson's disease. We are very much honored to have the chairman of the Tactical Functional Neurosurgery Committee of the WFNS with us today. In this webinar, we are going to discuss the neurosurgical aspects of Parkinson's disease and how we select the patients and the surgical modalities that have been used for the patients with Parkinson's disease. I really want to share a few words on Parkinson's disease. Just let me. I would first like to appreciate everyone who has accepted our invitation to give their wonderful lectures today. And I think this is all the dedication of our wonderful neurosurgeons who are working so hard for the progress of neurosurgery, for the benefit of the mankind and all the diseases in the management and for the probable cure of a few diseases that is possible. In this case, in Parkinson's disease, which there is no proper cure, but we can manage it well with some very important things in the steps. I would like to share a verse from our national poet, Allama Muhammad Iqbal. Rang ho ya khishto sang, jang ho ya har posot. Maujazae fan ki hai, khune jigar se namod. That actually means that that neurosurgery, where like we say, that it is more a passion and less a profession. So I'm really pleased to make it more understandable for everyone because it is an Urdu version type of poetry. So neurosurgery is basically a passion more than a profession. The miracle of art springs from the livelihood of the artist. Philosophy, art, and poetry or any other form of art or activity is shallow if it is without and it is not being fed with the blood of your heart and the passion that you have for that. It's no more than an empty structure or word or sound or just a painting or just a simple plain canvas if you do not have the passion to do it. Be it a painting, an architecture, music, poetry, or calligraphy, all these arts thrive on the intensity of the love and dedication that you give to it. So it is the passion that gives chiseled stone into a beautiful structure, a beautiful sculpture such as that of Michelangelo. It is the passion that converted the canvas and paints into the masterpiece of Mona Lisa. It is all the passion. There is the same canvas, there are the same paints, but it's just the passion that differs. Same applies to the melody that is given to a simple harp, like the Beethoven melody. It is all the passion behind that created such masterpieces. Same applies for neurosurgery, which I will again like to emphasize that it is not a profession, it is just a passion. So it all requires passion. And I'm really happy to have the privilege of having such wonderful mentors who can actually give word to give life to neurosurgery, I would say. So again, thank you so much for all of my wonderful mentors who agreed to deliver their wonderful lectures today on the World Parkinson's Day. I would first like to invite Professor Ahmad Alhani. I think he doesn't need any, any introductions. He's such a huge name in neurosurgery. However, I would like to say that he was also the president of the SANS 2022 conference. He is also, the chairperson of Stereotactic and Functional Neurosurgery Committee of the WFNS. He's the regional vice president of the WSSFN. He's the president of the Middle Eastern Society for Stereotactic and Functional Neurological Surgery. He's the head of division of neurosurgery, King Abdul Aziz Medical City, Riyadh. He's also the head of scientific council for neurosurgery of the Saudi Commission for Health specialties. We are really honored and pleased to have you here with us today, sir. And he will be sharing his wonderful talk on a very important topic, on a very important title, that is the deep brain stimulation for Parkinson's disease, surgical candidates, and how to select patients for surgical treatment. Sir, the floor is all yours now. Thank you.
Okay. Thank you very much, Noor. Thank you for the introduction, and thank you for the poetry that you just said. It's a pleasure for me to be here. It's around 10 o'clock morning in Riyadh, and it's Ramadan Kareem to everybody who observe Ramadan. Let me share with you my presentation. Here we are. Can you see the slides, Noor?
Yes,
Yes.
sir, we can.
Okay. Okay. So let me first acknowledge a few things. Acknowledge the institute that I work in, which is King Abdulaziz Medical City, the University Al Faisal, and the Pan Arab Neurosurgical Society, the World Federation of Neurosurgery, and the World Society of Stereotactic Functional Neurosurgery. This is the new dream for us with the Neuroscience Center that's been under construction now and should be ready in about a couple of years. And only a few days ago, we finished our Saudi Neurosurgical Society meeting that happened in Riyadh. And we have put sort of a logo for our meeting this year is back to life, as we have 2 years of no physical meeting. Now we are back to a meeting where we can see each other and communicate in person. Today, we learned that online communication is very good, not as good as in person, but it's very good. And this is why we feel that webinar like the one that Noor is organizing today is essentially important to communicate with each other, to see what each other is doing and learn from each other. It's easy, accessible, you can always go back to it, and anyone from anywhere in the world can have an access and participate, learn, and communicate with the people all around the world. So thank you, Noor, for that invitation, and it's my pleasure to start my presentation on that direction. So our title today is Deep Brain Stimulation for Parkinson's Disease, how to select the correct surgical candidates. Just to start with James Parkinson, who first described the disease, we have to acknowledge that the name coming from this gentleman who described 6 cases of Parkinson's disease, and from that point, Parkinson became a famous diagnosis to a lot of patients with disabling neurosurgical, neurological condition that now has a neurosurgical treatment or neurosurgical way to help these patients, if not curing it. So it's not an uncommon disease. It's the second most common neurodegenerative disease. And we are talking about 5 to 35 new cases per 100,000 individual. It's rare in the young, but it's for inherited type of Parkinson. It's usually coming in the early part of life. In Saudi, for example, and because of consanguinity, we do have a lot of inherited type of Parkinson's disease, and it is not very uncommon to see patients in their 20s and 30s with disabling Parkinson disease related to inherited disorders. Globally, it's about 0.3%, but when we go to the age of 70s and 80s, it's becoming more prevalence, and we increased to about 3% of the society with some form of Parkinson's disease. For some reason, men are more affected than women, but this is life. So what is the really pathology with that? This slide showed, this montage of slides showed what Parkinson is all about. This is normal with a normal substantia nigra that is black in color, colorful one, healthy. Here we are talking on the other side of the small atrophied midbrain, no more black pigmentation. And this pigmentation comes from the substantia nigra neurons, which is laden with melanin-laden dopaminergic neurons. The amount of cells are less, the amount of pigmented content is less, so it's less in number and less in amount. And we should not forget that there is other pathology. It's not only dopamine, and it's not only replacing dopamine will help this patient, but there is a widespread of intracellular alpha-synuclein accumulation around the brain. And there's other also a neural population loss of neurotransmitter like cholinergic, serotonergic, and so on. So it's not only dopamine related, but the main feature is the loss of tissue in the substantia nigra, and we can see that easily here in our specimen. Genetics is everywhere, but we should remember that only 5% of patients with Parkinson's disease has a genetic background, and again, it's different in different parts of the world. We can radiologically diagnose Parkinson's disease, but this is not frequently happen. We have a lot of advanced radiological tests that it can help to include or exclude the diagnosis of Parkinson's disease, make it more likely. But in general, we do diagnose Parkinson's disease by clinical criteria, and these clinical criteria get revised every now and then. But the bottom line is Parkinsonian features that I'm going to come and talk about it in a minute, and with add criteria here, criteria there to include the diagnosis of Parkinson's disease as compared to Parkinsonian feature of neurological disability. And we all know about the medical treatment for Parkinson's disease. Either we go with the dopaminergic support or non-dopaminergic support, and all related to replace the dopamine loss that we have in the central nervous system. I'm not going to go into details of this. But there's other non-dopaminergic treatment also, and it's coming in the market more and more. I'm not saying it's threatening the treatment with deep brain stimulation, but definitely it opens light for hope for patients with different features of Parkinson's disease to have a better control of their pathology, of their disability with the disease. We have to remember that Parkinson's disease is not like a static disorder. It's not like a ischemic disease that happens and continue, but rather it's a progressive disease. And I like to sort of look at it like we talk about diabetes, that type 2 diabetes, we start by having control of lifestyle, you then start to have a better food control, then you start to have medications that help not to increase the blood sugar, to reduce the blood sugar, then you reach into insulin, then you reach to bad complication of Parkinson's, of diabetes, how we can control it. And here we have divided this into the motor component, the non-motor component that usually happen earlier in the diagnosis of Parkinson's disease, but usually get missed as many people relate this to the contemporary lifestyle that we are in. But once the motor components start to show, now it's becoming more obvious, especially when tremor showed up. Rigidity, it needs a physical exam, bradykinesia or akinesia. Many people attribute it initially to the non-motor symptoms, to the anxiety, to the depression and stuff like this. But as the disease start to progress, it start to have this sort of stereotype picture of Parkinson's disease that we are going to come into it in a few minutes. So it's an early stage. It depends how the patient start with the tremor. They usually provoke the diagnosis very early because everybody will be able to observe the tremor and go to the neurologist for that. As the time passes and diagnosis get established with the bradykinesia, with the rigidity, we start to have the problem of the medication itself. And from here, we start to have the fluctuations with the medications or dyskinesia, which is drug-induced. And then after that, we start to see the late complication of Parkinson's disease with the postural instability, with the autonomic nervous system, and then gait disturbance till the end stage Parkinsonian features and till the patient get being disabled. So this is the scale how Parkinson's disease goes, and we are going from here to here not by days, weeks, but rather than by months, sometimes decades, from the early diagnosis till we reach the end stage. So it's not a disease that we observe over our practice, but rather than a disease that we hear from the family that they start about 10, 15 years ago, and then slowly till you reach the stage where the patients will go and seek surgical advice and surgical intervention. So not to forget that at the end, at the late stage, dementia becoming very important factors, psychotic problem, and autonomic nervous system becoming very important. And this also has to be handled by the appropriate team, as the neurosurgery usually cannot help much with these symptoms. So Parkinson's disease surgery is not something new. It was the only hope for patients in the 60s, where patients used to have radiofrequency lesioning, usually in the globus pallidus and in the thalamus to help the tremor predominant Parkinson's disease. But as soon we come up with the introduction of L-DOPA in the 70s, that makes surgery almost down to stand still. No one talks about surgery anymore. But in the early 90s, with the complication of the medications, with long treatment period with the L-DOPA, we start to see complication of L-DOPA that I'm going to come to talk about it in a few minutes. And we can see some patients who cannot tolerate the L-DOPA, or their tolerance to L-DOPA getting less and less with time. So this is why people re-looked at, revisited the option of surgery with the improvement in neuroradiology, in neurosurgical technique, in navigation, and in neurophysiology. We start to be able to do our surgical intervention in terms of radiofrequency lesioning or in terms of implanting deep brain stimulation more accurate, and that will lead to better clinical outcome and safer for the patient himself. And today we are going to talk only about the modern surgical intervention that we do practice in the last like 1 decade, for example. So we're not going to go to the early days. So this is one of the most important slides when we talk about indication for surgery. So as we said in the beginning, Parkinson's is not a static neurological disorder. It's a disorder that starts usually in the non-motor phase, and then once the motor phase start to show up in terms of symptomatology on the patient, it starts to grow slowly with time, months to years, till it gets established. And once get diagnosed to have Parkinson's disease, then it's the neurology part who usually start with the patient in terms of diagnosis, in terms of neuroimages to rule out some other disease that can manifest by Parkinsonian features, and then start the treatment. And this is classical, as we said here, like look at this figure in panel A. Patient usually start on L-DOPA, for example, twice a day, 3 times a day. So you take your pills, slowly you have the benefit, and you enjoy the L-DOPA. Then the benefit of the medication start to go down. Then it's time for the next dose. So this classical initial excellent results from starting replacement therapy with L-DOPA. So no dyskinesia because we have not reached to that stage yet. And the therapeutic range is quite wide. And akinesia can be very easily prevented by having regular medication time. That's usually 2-3 times a day when we start. So this is phase 1. Everybody is happy. You diagnose Parkinson, you got medication, patient is happiest man on earth, found treatment for his disease. But this is not the end of the story. It gets complicated later on. So as the time passes, we start to have the benefit from the medication, but doesn't last for too much. Then it start to come down. We go back to akinesia or bradykinesia. Then we take another medications. Then it's getting better. Then less. So as the time passes, we move from 2-3 times a day to 6 times a day. Keeping that we do not want to see the akinesia phase, and we do not want to reach to the dyskinesia phase. If we go that the dyskinesia incidence about 10% per year, so usually it takes 5 to 6 years to start to see the dyskinesia phase of Parkinson symptomatology. So here we have an excellent control for the patient with medication. Here we have very good reasonable control for the patient with medications, because we can still keep the patient in the therapeutic range, not to reach the dyskinesia and to avoid the akinesia. And I know patients who receive their medication like once every 2 hours or once every 1 hour to keep themselves in the therapeutic range. But the story doesn't end at that phase, but rather go to the next step. And here are the steps where things go in a bizarre fashion. You take your medications, you're doing well, maybe there's a peak dyskinesia. Okay, we cannot avoid it to have no akinesia. We have to see some dyskinesia, drug-induced dyskinesia, which is okay. But the patient takes his medication, peak of medication dyskinesia, and then back to baseline. Then it's time for the second dose. The patient take the second dose, but no benefits. There is no benefit from that dose. Then he take another dose. Then suddenly we jump into dyskinesia phase. So the patient will go in an unpredictable on-off phenomena. This is what we call unpredictable on-off phenomena. When the patient with the medication he takes suddenly moves from off to on with dyskinesia to a good therapeutic range to akinesia, to dyskinesia. This bizarre on and off phenomena is one of the most difficult thing to treat by medical treatment, by medical management. And this is where the patient is like ready for surgical intervention. The unpredictable on-off phenomena. And what bothers the patients the most is that they feel themselves in the therapeutic range with a classical story, that they feel themselves in the therapeutic range, they feel happy, okay, then they go, for example, for a walk. They go, for example, to the shopping store to buy something. So in the middle of the way, they suddenly go to off, freeze completely. They cannot progress to the store. They cannot go back home. This unpredictable on-off has a major impact on the patient clinical performance and quality of daily activity. So once we reach to this stage, this is definitely the time that neurosurgical intervention is indicated. So I want to keep that slides always in mind when we talk about indication, selecting patient. In here, you do not need to interfere. In here, it's the start to discuss neurosurgical intervention. It depends on how frequent you need to go on and off, but it's predictable. You can still control it with medications, but maybe early or late surgical intervention is indicated. Once we reach to this stage, there is no other options, at least from medical point of view, apart from going to surgical intervention or maybe some other modern options like levodopa. We talk about that later on maybe. So what options we have? We have in surgical option. We have the deep brain stimulation, that will be the focus, radiofrequency lesioning. Nowadays, we have something called focus ultrasound, which is replacing some of the indications. Gamma knife has been there and it will continue for some time, and some other experimental options that has not proved yet to be of major value in managing patients with Parkinson's disease. This is the circuit of the internal of the basal ganglia, and I like to remind myself with this diagram every now and then. This is the substantia nigra compacta. This is the striatum. The influence of the dopaminergic cells here onto the striatum is by the direct pathway and the indirect pathway, which goes through the GPE to the subthalamic nucleus. The D1 is to the GPI. So the subthalamic nucleus has the authority to control both the GPI and the SNR for the output of the basal ganglia that's going to go to the thalamus and to the brainstem, and from there back to the cerebral cortex. So this illustrates somehow why globus pallidus intervention has certain benefit and subthalamic nucleus intervention has other benefit. Both helps some symptoms of the Parkinson disease, but may not be exactly the same. So they're not really competitive in that sense. So we go back to the clinical part. So when we talk about Parkinson's disease, when we talk about improvement of Parkinson symptoms by deep brain stimulation, we focused our attention to few symptoms. That's the motor symptoms. So we talk about the akinesia, hypokinesia, bradykinesia. We talk about tremor, so this is something very easy to measure, to evaluate and see pre and post in a very specific way. We talk about rigidity, and we scale it from 0 to 4, gait and balance, and then the amount, the severity of drug-induced dyskinesia. So whenever we talk about deep brain stimulation for Parkinson's disease, we aim at seeing improvement in these 5 categories. Based on that, we say that this patient has improvement or no improvement, or we focus our surgery to which symptomatology that's affecting the patient quality of life the most. So who is the surgical candidate for deep brain stimulation? Number one, idiopathic Parkinson disease. And this is why two things. You need excellent specialized neurologist to be able to examine the patient and tell you that this is an idiopathic Parkinson disease, not Parkinsonian feature from other pathology like microvascular disorders or other disease that can mimic Parkinson disease. And we are featuring only idiopathic Parkinson disease. One of the hints about that is the early response to L-DOPA. So if you have a patient who improved significantly by the start of his disease career, let's say, or a course with clear-cut improvement to L-DOPA, that's make it more in favor of idiopathic Parkinson disease, and that will make us more into surgical intervention, knowing that this patient will do better after surgical intervention. Medical management, so not the minute you get diagnosed with Parkinson's disease, you go and see your neurosurgeons. It's not the other way. If you go to your neurologist, and once the neurologist feels that that's it, this is the limit that I can help, then he will refer you to the neurosurgeon to see what are the options for you in specific in terms of neurosurgical intervention. So it's sort of a teamwork, like a partner, a neurologist and a neurosurgeon, and I will come to that at the end of my talk. You cannot do without. You cannot do Parkinson's surgery without an excellent neurologist, and the neurologist, once he's more into advanced patient with Parkinson's disease, he's going to look for the neurosurgeon who is going to help him, same like epileptologist and epilepsy surgeon. Cognitive and psychiatric disturbance, as we have seen in the previous slide, that the non-motor component of Parkinson's has a major psychiatric elements, but we have to make 100% sure that we are not talking about psychological problem related to the diagnosis of Parkinson's, i.e., like once someone gets labeled with Parkinson's, many patients I do see that they go into depression phase and start not to perform at that level, not because they have a psychiatric disorder, but rather than depression related to the labeling themselves as a Parkinsonian patients. When we come to age, our patient with inherited Parkinson's disease, they do very well with surgical intervention. They are young, healthy, they can tolerate the surgery very well, and they improve significantly with deep brain stimulation. So the 5% of inherited Parkinson's disease are excellent candidates for surgical intervention. Although their course in the disease may be different, the natural history may be different, but they do improve to neurosurgical intervention in terms of deep brain stimulation. When we come to age, as we have seen that the more you grow, the more prevalence of Parkinson's disease, the more your patient will be in their 80s. But we have to put like sort of a line. In our program, we used to have 70 is our sort of cutoff line, that more than 70, we do not operate on these patients. Less than 70, we do. Sometimes we sort of broke the rules. I'm not saying we regret, but definitely once you reach the 70, your tolerance to your surgical intervention get less. So higher incidence of complication and less ability to tolerate complication. So 70, maybe maximum 75 is way to go. Insurance companies plays a major role. Regulations of programs plays a major role. They usually put a cutoff age where they don't permit surgery after a certain age. Although patient may be healthy otherwise, and he may tolerate the surgery with no problem, but that's age. I do not want to make it a discrimination point, but reality that the body may not tolerate the complication of the surgery when you go in the advance in your age. Other major medical problem: uncontrolled blood pressure, uncontrolled diabetes, being in need for anticoagulant, having a major renal impairment, major hepatic impairment. All this is very important factors in our decision to go for surgery or not. If the patient in their 60s and 70s has a major medical problem, we tend not to pass them the test for surgical intervention because the complication will be much higher and their tolerance for the surgery is less and less. So we have to balance that very well. So when to do the surgery? This is a very important slide, and I want to stop here for a minute. We went through the clinical scenario. We went through the fluctuation. Once you see that sort of fluctuation, we know that it's time for surgery. We don't need to reach to the advanced that before we refer patient for surgery. We can go earlier. The time the neurologist, the expert neurologist feels that we are getting there, we can start the progress of investigating the possibility of doing neurosurgical intervention. You need to have the support to have the deep brain stimulation. You need to have it done in a safe place. They're doing the surgery frequently. But most important is the family support, the social support for the deep brain stimulation, and ability to have access to people who can control your deep brain stimulation programming, reprogramming it, and be able to change the battery. Many patients we have in our program, they came from neighborhood countries where we know they don't have support for deep brain stimulation at that time. So we tend not to go for deep brain stimulation option because we know that we're going to put the leads, we put the battery, he's better, excellent. Now he has sort of a lot of new plans in life and new tasks that he can complete. And then he goes back to his home country and there's no support there. And this is why sometimes we go to lesioning options for these patients, because better to have some benefit rather than to have an excellent benefit for a short time and suddenly you are back to square one. One of the important things is level of expectation. You need to see in front of you a patient who understood very well what is the neurosurgical intervention, what is the scope, how much improvement, and how much we cannot improve. And I do recall a patient whom we put his video everywhere that an excellent results of surgical intervention, pre and post. But when you ask him, Mr. X, how's everything? Are you happy? He said, no, I'm not happy. So why? You look how you were before and how you are now. So I thought I'll be cured. I'm not cured. I still have Parkinson. I still have some symptoms. I still have some of the problem. And I still need to come back and see you every few months, for example. So it's not a cure. So it has to be very clear with the patient and his family. It's the level of expectation. And one of the things that we do is that we do a challenging test for these patients with the help of the neurology team, where we see the patient before taking the medication for some time, then we give them the medications in a certain dose, and you see the benefit. And we tell them, look, don't look at the fluctuation, don't look at the off part of it, look at the best on in this category. This is your maximum benefit. This is your 100% improvement. If this is okay, we go for surgery. If this is below your expectation, then there is no point in going for the surgical intervention. So extremely important to sit down with the patient and understand from him what his level of expectation, and make sure that he understood from you what you are looking at as an aim of surgery. Early versus late. There are more and more studies now showing that you don't need till you reach to the pure line of indication for surgery to start the process of deep brain stimulation, but you can go earlier, and that may relate it to delaying some of the late complication. So there are a lot of studies now coming up with exploring the benefit of early surgical intervention, not too early, but early in terms of before you reach to the unpredictable on-off phenomena, that you can help the quality of life, that you can help to keep the patient in their performance status. He's still an employee, he's still working, he's still in his reasonable level of performance, and it doesn't need to take him from a very unpredictable on-off to reasonable retirement sort of phase. So sometimes early surgery is a valid option, but not too early. So when not to do, when it's too early, when it's very easily manageable by oral medication, when it's too late, HNY stage 5, for example, is bedridden, where surgery does not help. And the most important is to see this patient during his off and his on. You need to see him during his off because this is your baseline of improvement. And you want to see him during his on because this is his maximum improvement. So if the amount between on and off is marginal, then there is no point of putting deep brain stimulation. But when the difference between off, almost bedridden, to on, almost normal, these are the excellent patient candidate for surgical intervention because your aim is to help to push that off stage up to the end stage, to the on stage using the deep brain stimulation and reduce the unpredictable on off, which is by far one of the most rewarding results from deep brain stimulation, that this up and down, that really makes the patients tired and unsure of his performance. We go to a reasonable on and off that can keep them within the therapeutic range or nearly the therapeutic range, and that will give them a good boost in terms of their quality of life tasks. Again, psychiatric problem has to be ruled out by a psychiatrist. Memory is very important because we know that deep brain stimulation, especially in the subthalamic nucleus, may have some impact on the memory. So you have to have a patient who is in an excellent IQ performance and excellent memory status. If he has some deterioration post-op, he still perform at a reasonable level. Dopa hunger, this is a situation that we see with a lot of patients when they start to take L-Dopa, they take their Cinnamate and they start to be almost addicted to the Cinnamate. So whenever you put your hands in their pocket, it's like full of pills of Cinnamate because every now and then they just chew one as if they are taking some sugar tablets. So this is a patient may not be an excellent candidate for surgical intervention because they are somehow addicted to that psychological benefit of taking the tablets. So the options we have is more into radiofrequency lesioning as of now, or focused ultrasound lesioning, destructive in a way, or stimulation in a way. And now we have, instead of one company, 3, 4, 5, I don't know how much now, who can supply with the lithium battery that can be rechargeable or not rechargeable, and different leads with different options that help to have a better improvement of the patient's symptomatology and reduce the risk of surgery. And with time, getting better quality of life for this patient and does not need to replace their battery very frequently. But these are the two main options, destructive versus neuromodulation. And the targets now getting less and less into controversy. Subthalamic nucleus, as we said, from the circuit of the basal ganglia, it helps better control of the symptomatology of Parkinson's disease. It helps with the amount of medication received, the fluctuation on and off. So subthalamic nucleus, I'm not saying it's superior to GPI, but I'm saying it's a very valid option that many centers put it as #1 option for surgical intervention. Globus pallidus is #2, and we do use it sometime in some of the patients, especially when we go to lesioning, or if the patient has some psychological feature that we feel GPI is better than STN. Thalamus used to be in the past for tremor predominant Parkinson's disease, and then it fades because the benefit from subthalamic nucleus is as good as the thalamic stimulation or thalamic DBS. However, recently with the focused ultrasound, people start to revisit the option of lesioning by focused ultrasound and go back to the thalamus and lesion the VIM, hoping to improve the tremor in a patient with essential tremor or patient with the predominantly tremor Parkinsonian features. And this patient may improve very well, especially in areas where they don't have the support for deep brain stimulation, as we said before. PPN has been suggested for axial component for gait problem with Parkinson feature and has evolved for a certain level, but the golden standard now is STN deep brain stimulation, unless the patient has some other specific and unique features of their pathology. So again, STN versus GPI, I don't think anyone has approved that one is superior to the other, but vast majority of neurosurgical centers adapt STN DBS as #1 choice unless there is a specific reason not to. I'm not going to go in the technical part of the surgery, how we do it, but now we do it much easier, much safer than before. We do an MRI, locate where is the STN, we fuse it to a CT scan for better quality. We still use the frame. Some people use frameless, some people use robots. Different centers use different technique, whatever they feel themselves comfortable in doing it. At the end of the day, you want to put your electrode in the best location and avoid complication from that insertion. And this is the bottom line. I'm not going to go in details of the surgical intervention and how we look into a direct and indirect pathway, but nowadays we do CT MRI fusion. We still use the frame, and we start to do it under GA. In the past, we like to do examining the patient during the surgery to see the benefit. Now, many patients go through to a general anesthesia with an electrode in place, using images to ensure that we are in the right spot, and then wake the patient up and put the battery later on. So the discussion about intraoperative mapping and micro recording and macro stimulation, it's definitely there. Each center adopt their own pathway, and I feel respect to all of them the way they are doing it, if they are doing it with good results and less complications. So this is for people who are not much familiar with this, the issue is to implant an electrode in the right target, for example, here the subthalamic nucleus, and this will be connected to another wire taken to a battery in the subclavicular area here with the electrodes that used to be 4 in the past, but now we have a lot of options in terms of contact, and that will change into the programming of these patients later on after surgery. And here we have the intraoperative images to see that the electrode is in the center of where we want to be, and then we can do that with images later on with whatever options you have, like OR, intraoperative CT, and stuff like this, to ensure that your electrode is in the correct place, and you can confirm that neurophysiologically if the patient is awake by neurophysiological stimulation, and see the benefit of the patient and reduction of the symptomatology and avoiding complication with stimulation. I'm just going to share with you an old video. You know, nowadays it's very difficult to video patients in our hospital. This is like an old one with all that consent for that. But let me show you a classical patient. Okay, so this is 2003 when we started, and maybe I lost a few kilos from that time. So this patient with a classical akinesia, rigidity, there is no tremor component in this is the gait problem that he has. He walk few steps, then freeze completely suddenly, stay where he started. You see that? Classical petit marché sort of gait, and suddenly he freeze and stay still, cannot move. And this is the drug-induced dyskinesia. Interesting, when you ask the family, they do not like to see this. They like to see the first father or the first partner, because he looks more, quote unquote, decent. But if you ask the patient, he would prefer to be like this way much more than the previous image, because he feels himself alive here. He still can do things. You focus on the way he's eating, how he control his tremor, how he control, his dyskinetic movement, he control it under his clothes, and then once it's settled down, he go and take a one bite and go back to his dyskinetic move. And this is him with his gait, with the dyskinesia. That can be sometimes very worse, that you need to strain the patient and not to hit something and break his arm or their legs or fall down. So even that, he is okay with this drug-induced dyskinesia. And this is at the time of surgery at that time. At that time, we used to do it with microelectrode recording. And this is him post-op. And he's using his left hand, not because of anything, but he has some problem with his right hand here, and that's why he doesn't want to show it on the video. But he can use either hands, okay? And he's eating okay without a problem, drinking. So he's not in that off stage, and he's not into this kinetic on stage. And then I ask him to walk. So you see how he is doing it now. He's not during off, not during this kinetic on, and he's able to have a decent walk. This is a second patient with predominant tremor, Parkinsonian. This is not essential tremor. This is a patient with Parkinson's disease. Of course, now no more patients to see. So this is him with the resting tremor, chin tremor. I'm asking him to put his over my finger. So this is him after subthalamic nucleus deep brain stimulation. In much better control. And you know that patient with tremor component, they don't improve very well to medical management, unlike rigidity and hypokinesia with L-DOPA. So this is him pre, this is him post, performing very well, doing STN stimulation. So when we talk about surgical outcome, you compare yourself to other centers, and you are able to tell the patient more informative way that you are expecting improvement by what. So most important that you define your unified Parkinson's disease rating scale during on and during off. You go by activity of daily living with your UPDRS second section, and the third one, which is the motor component that we said earlier that this is the focus of your surgical intervention. And with that, anything between 45 to 60 is a very reasonable average improvement. We have seen patients who improve like 85 and 90%, and we have seen patients who did not reach the 50s, but on an average 50-60% of UPDRS section 3 during off is a very reasonable outcome in terms of DBS stimulation. And again, the patient's condition during the L-DOPA challenging test, when we see him during off and we gave him the challenging L-DOPA, you see him during on, avoiding the dyskinesia and avoiding the unpredictability, looking at the on component, this is what's the best you can reach by your deep brain stimulation. So total daily dopaminergic drug dosage is reduced by 60%, of course, because you are replacing the mechanism of the L-DOPA. This is not same like globus pallidus, because these patients do not have drug-induced dyskinesia, and this is why they may increase the dose of the L-DOPA rather than decrease the dose of L-DOPA. And dyskinesia, because of the less dose of L-DOPA, will have a dyskinesia decrease by 60-70%, which is an excellent result. So as a frame, this is a very reasonable results in terms of outcome to our surgical intervention. And this is very important in the consent, and very important to make sure that the patient can understand the aim of the surgery. So what if it can be better? What if the location is not in this, slightly 1 millimeter anterior, 2 millimeters posterior, stuff like this, with better outcome? Yes, definitely. You can always, I like the word that said excellence is the enemy of good, but once you have a reasonable insertion and it's a good place, it's very important to accept and improve with the programming. How can we make the surgery easier on the patient? And now we move to a general anesthesia, avoid complication like this small venous infarct that happened to one of our patients, and that improves slowly with time. And better programming, because of the number of leads, direction of the lead, we can have a better programming for our patients post-operatively. Hardware issue is very important. The patients, they have to know that there's no zipper that we can change the battery every 3 years or 4 years after surgery. these wounds can suddenly dehiscent and the hardware may come up, and that will lead to stopping the benefit from surgical intervention. Breakage in the wires is also something we do see, not very frequently, but we do see, and this will lead to loss of benefit from the surgical intervention. So you have to put it in mind, the hardware issue. Nowadays, the focus ultrasound, I'm not saying replacing DBS by any means, but there's a category of patients whom you do not want them to go through the deep brain stimulation, and they have a predominant tremor. They can benefit from focused ultrasound. Now the LEADS has different directional, different options. I'm not here to advertise for anything, but this will make the programming easier, the programming with better results, and avoid complication by directing the output of the electrode into certain area and avoid it from others area, and this will lead to maybe a better improvement in the patients. Batteries evolve from this to this, and regardless of kind of company, programmable, non-programmable, things are improving on this line, and I'm sure we are going to reach a stage where the battery will be lifelong and does not need to be recharged or replaced. But it's just a matter of time. But you have to allow the progress of the technology to take place before we reach to that stage with a smaller battery and years of service. So it's not anymore a debate, DBS versus lesioning. It's what customized to the patient himself. What kind of symptoms? How can we help him to have the best benefit of our intervention? And this will make us more into the decision of going to DBS versus lesioning. So that debates in terms of DBS versus lesioning or STN versus globus pallidus is getting less and less. And we are now more into tailoring our management to our patients based on the symptomatology, the support, the expectation from his point to surgery. How can I conclude? We are still looking in improving technology, and it evolved very well in the last 30 years from unable to have the patient to sometimes excellent control of the symptoms, safer with the most improvement profile after surgery. It does not stop the progress of the Parkinson disease, although there is some studies that suggest it may play a role, but in general, we need to understand the natural history of the Parkinson disease, and the patient should understand the natural history of the Parkinson disease before we interfere with neurosurgical intervention. And days will come when maybe have some novel approaches outside the deep brain stimulation, like how focused ultrasound came into that tremor predominant category. So maybe have some other options, hopefully not in a destructive, but in a more neuromodulation way that can benefit patients with Parkinson's disease. Here, I want to attribute some of my improvement in putting DBS to my partner neurologist. This is 2002 with Dr. Saeed Bouhlega, Professor Saeed Bouhlega, who's our specialized neurologist. So I'm the young guy who started doing surgery, and he's the middle age at that time. The expert neurologist, we started the program together at King Faisal at that time with that logo, and started doing the surgery together. And here we are some years after, when he becoming a retiring professor, and I was still in my pre-retirement phase, as you can say. But I want to say thank you to the gentleman who helped making this program possible, because you cannot do without an excellent neurologist for diagnosis, early management, and even post-operative care for this patient. Thank you very much. This is the Middle Eastern Society. We had the last meeting. Hopefully, maybe in Pakistan, we can do the 4th meeting in a few years.
Amazing, sir. That will be a huge thing for all of us. Thank you so much, sir. We will be certainly looking forward to have the honor of hosting that wonderful meeting, and we actually need it. Thank you so much for the amazing lecture. I'm now inviting Professor Asif Bashir. I'm really honored to have learned from him under his very kind mentorship at PIN. So I'm really inspired by how he really owns his patients and owns his students, owns the women neurosurgeons as well, which is very good thing, a great achievement for Pakistani neurosurgeons. And he's a very competent neurosurgeon. He will be teaching he will be, the title of his talk is The Noble Art of Listening to DBS, the Deep Brain Stimulation, Current and Future Applications. Professor Asir Bashir is an American diplomat. He's an MD and fellow of the AANS and fellow of the American College of Surgery. He's a diplomat of American Board of Neurological Surgery. Right now, he's a professor and the head of Neurological Surgery Unit at Punjab Institute of Neurosciences, PINS, Lahore, Pakistan, which is the largest private sector public sector dedicated neurosurgical institute in our province of Punjab. And I'm really honored to be affiliated with that same institute and honored to have learned from sir. And he's amazing surgeon in deep brain stimulation in Pakistan. Sir, the floor is all yours now. Thank you so much, sir. It's a huge honor for us to have you here today.
Thank you. First of all, I want to confirm everybody can see me and hear me, with the Wi-Fi.
Yes,
okay, great.
You want to be in the presentation mode, correct?
Excellent. That's what I'm going to do right
Yeah,
How's
there
that?
you go, perfect.
Perfect. Okay, so it's an honor to follow Professor Ahmad, and I think he has covered a lot of things which most of the people need to know. And so glad to follow his talk. So I'll briefly go through this because I think we're running a little late on time. So, Noble Art of Listening.
So you can take more time if you require, because we will certainly have the honor. We will be pleased to listen to you. So, sir, please be easy with that. We can accommodate.
Okay, great. So first of all, no financial disclosures. Like Professor Ahmad has already mentioned, neurology is the key in this. It's an extremely intricate team and surgery. Always give credit to Mayo Clinic. That's where I was after my residency, I went to Mayo Clinic. It's like almost 2 decades ago now. But Kendall Lee, good friend, I'm sure people know about him. He's the chief of movement disorder functional at Mayo Clinic. Neurologist at that time, the team is all here. Wherever you go, I have transitioned to Pakistan over 4 years ago now. So after being over 2 decades in US, we moved here. Initially, we made a team in Ohio, then at JFK in New Jersey, where I still operate every few months. Are we having a little difficulty moving? Let's see. Okay, good. So again, there's always a team anchor in US. We had, other than the neurologist, it was Jackie Christini. Like I always say, MasterCard, it's a priceless. There's something money can buy. She's the anchor person who's always involved with the patients and involved in the programming and all of that. We built this team here. We are very fortunate to have Dr. Zubair, and we started initially with, like Professor Ahmad mentioned, I have been through fortunate to have tried all the implants. In US, we were first ones to transition to Abbott, St. Jude's in 2015. More because of the direction leads, and then followed by, initially it was Medtronic and now Boston Scientific and the 2 Chinese implants. We have been very proficient in using, and we can tell they have a role in every patient's life. I think you can pick and choose according to pricing and all that, especially when you're in an underdeveloped country like Pakistan. When you're in a developed country, I think it's not an issue, but this is extremely important. This was our first patient we did, I would say in 2018, early 2018 after I moved. So this is our team now. As I mentioned, Dr. Zubair is here in neurology. Some of the neurologists, Dr. Nabil Syed, is a neurologist who has been trained in US and has just come back. Neuropsych eval is also extremely important. Some of our friends at Queen Square, we've been fortunate to have close interaction with. This is the DBS stimulation format, how we do that. Our illustrious previous speaker has already shown 2 leads connected to a generator. So these are the current indications. Essential tremor, which we don't get to see that much here in Pakistan, but Parkinson disease is the mainstay. Dystonia is a fair number now. Of course, intractable epilepsy, Tourette's, treatment disorder, the depressive, the psychiatric indications are upcoming. Still don't have the right target for that. Some cases in the East, in Korea, in Japan, TBI, disorders of consciousness. Again, PD, STN, subthalamic nucleus, GPI. I think predominantly most centers now do STN for DBS now. GPI is the second target. We do dystonia with GPI, globus pallidus interna. A few with thalamic VIM also, where the tremor is not under control with the STN. Emerging technology, all of these indications are the future. There's no doubt that we are still at the tip of the iceberg with the newer technologies coming out, with the new electronic vehicles coming out. I think the technology is just changing. And I think we are very fortunate to be involved with this functional neurosurgery, where epilepsy, depression, chronic pain, Alzheimer's is going to be the future. This is and obesity, hypothalamic centers. Steve Bloomfield, I show this picture every time. We've traveled, we've operated together. One of my close friends back in New York, in New Jersey, we traveled to Korea 2013, where I spoke on this. Again, Professor Lee. Picture I see here because Professor Lee is one of the founders of modern functional neurosurgery in Korea. But his father and my father, Professor Bashir, who did the maximum lesioning in those days, were also colleagues. So again, established early PD, early surgery for PD is found to be now superior to medical management, especially if it's done in the first 10 years. Like Professor Ahmad showed, there's a golden period. Timing is important. So if it's too early, I think you end up and you risk the patient with undue risk. But if it's too late, then the patients don't get the same. So it's like a window. It's a golden period where you want to be able to convince the patient to go for the surgery. So ideal if it's done between 5 to 10 years. So some of the videos, I'm not going to take you through this. This is some of our initial at Mayo Clinic, pre-op, Gary, a lot of bradykinesia, tremor, difficulty with walking. Are you getting some? So you can see how difficulty walking, short, typical Parkinson after surgery, 8 months. So this is just like Professor Ahmad, our initial cases, long time ago, I would say. But we have evolved over a number of years. So no difficulty walking. I spent a lot of my life in very cold areas like Minnesota and Chicago and upstate New York. So I think it's nice to be back in Pakistan now. But history of DBS, I'm not going to go through the details. Professor Ahmad Alhani has already gone through this, but this all started in the 1950s, in fact, from looking for treatment for schizophrenia, for psychiatric treatment, not for Parkinson's disease. And then the stimulation came in 1960s. It was the VPL, VPM for facial pain, thalamotomies came in. And then 1960s and 70s, levodopa, when that came in, everything stopped. So 80s, there was renewed interest in surgery, and then radio frequency, as well as later gamma knife targeting started after 2000 as we moved forward. So 1987, Benabid in France was the first one to do chronic high frequency thalamic deep brain stim for tremor. Later, he reported on subthalamic nucleus also. In US, where I have been since 1997, the FDA approved the thalamic DBS for tremor. In 97, 2002, it was approved for GPI and STN, and later humanitarian for dystonia also. 1960s, so Pakistan has been very fortunate in the sense that lesioning using a Lexel stereotactic frame started in 1960s when happened to be my father, Professor Bashir, who came back from UK, from Newcastle. And this is the initial Lexel frame. I showed that to all the students and all the fellows and who are training, because I think the previous generations have done wonders. We have just crafted, and with the technology and all that, we are moving to the next level. But this was all being done. Radio frequency lesioning. In fact, there were 1144 cases from 64 to 88 that involves a time when the when levodopa came in also. So over 1,000 cases were done in Lahore, Pakistan, before we even thought of getting into neurosurgery training. At least I can say that. So this is a lesson for the younger generation. Now in 2022, of course, Lexel frame. If you're doing DBS, we are still doing frame-based. We've done frame-less also, but accuracy is still better with frame-based. Other than Lexel, we've used the German Inomed frames also now. In Pakistan, we're using that. So, and then a lot of interest in gamma knife radiosurgery or any stereotactic frame system, because Pakistan is an underdeveloped country. So we see a lot of patients who are non-affording. So I think lesioning still has a lot of role. We do them with MER, especially for the STN. We've done all of these. We've done Medtronic, we've done St. Jude's, Boston, Chinese. I named them specifically because right now we're using the rechargeable for most patients. And the reason we've switched to rechargeable is that when I started in Pakistan in 2018, I started seeing that within 2-3 years, when the batteries were depleting, the patients could not afford. They have to pay. There's no insurance system. So now we give them Boston Scientific with 25 years of life, or Sindre Chinese, which is now coming for 15 to 25 years. So again, this is the setup. This is an intra-op MRI guidance. We usually get an MRI as an outpatient. Some of the pictures. I'm not going. There's a lot of videos to show, but let's just move on. Pre-op, we always get preoperatively. We make them draw. This is the right. This is the left. Post, intraoperative stimulation while the patient is awake. Interesting video. In fact, this is Jackie, and this is not too, I would say 2016 or 17. So pre-op. In fact, after the surgery. So this is right. This is after turning it on now.
And izquierda, grande y rápido. Straight.
Significant improvement post-operatively. So you need the caveat over here is that the patients need to understand that they need to have multiple programming sessions. It takes about 3 to 6 months for them to really get comfortable with the. So much stable. He could not even drink water before. Okay, so DBS Park experience, we need to update. I think we've done close to 60 patients now since 2018. High 50, late would be ranging from 30 to 74 age group. We've done more than multiple GPIs now, so this slide needs to be updated. But STN has been our target for most of the patients. Bilateral resulted in significant persistent anti-Parkinsonian effect with improved quality for life, which is comparable to a DBS experience. So again, these are the systems. Whatever is available, we use them. We get a MRI as an outpatient. On the day of surgery, we put a frame on and then get a CT and then fuse it on the IPS training with the Inomed or the Medtronic frame link system. Implants, like I mentioned, Boston Scientific. In fact, this was the first patient in 2018 in Pakistan. Post-op. So So the key is to have selection, and I think this is where the neurology team is extremely important. They need to be able to work with you to be able to find the right patient, and preoperative, postoperative UPDRS scoring is the caveat which we normally use. So this is a dystonia patient, and I show this because this is in 2009, and the patient had a bent neck. She had this spasmodic torticollis, and this is on. So if it's US, so July 8th of July 2009. We offered GPI and told her it'll take about 6 months. So they are always exceptions. We never expected, but this is the next day when the patient sent me in the morning. So this is July 9th. So her neck was totally straight. So some patients respond to instant stimulation also, but most of them require about 3 to 6 months of stimulation from dystonia. This is a very interesting writer's cramp dystonia done here in Lahore. Difficulty. We just did one, in fact, 2 weeks ago also, a young girl. So can't write, just on writing. And then this is post-op. He's able to write. So a lot of remarkable results, but it's unpredictable. You can't really promise. So this is a unilateral GPI for writer's dystonia on the left side. So again, emerging indications for DBS. This is where our interest is. Epilepsy, Tourette's, all these, like I mentioned. I think last two are the ones, and as well as TBI, disorders of consciousness, as we move forward with all the research going on. So this is, I'm sharing this from our colleagues from my time, as well as collaboration with Mayo Clinic. So all these are important. The fusion from neurochemistry, from neuroanatomy. We've used 7 Tesla imaging also, what we can see on the high-end imaging. So this is a comparison between a 1.5 Tesla, what we use normally, to a 7 Tesla imaging. So if you can see it, you can stimulate it and always reverse it, because it's not permanent, it's not a lesioning. So you can tell how the right-sided image, you can see the finite details of the tracks, of the fibers and all that, which is amazing. So what are the mechanisms of DBS? This is a question a lot of patients ask, a lot of students ask. Answer to that is, we don't know why it works. DBS activates astrocytes. This is the presumptive. It increases the intracellular calcium. There's, of course, vesicular fusion. There's glutamate, which is an excitatory neurotransmitter. And then there's modulation of the neural network. That is what causes our Tourette syndrome. I think this is something which we'd like to share also. This is a patient before surgery with Tourette.
Can you do this with your right hand?
So vocal tics, motor tics, unable to do that. He's not acting for sure.
Now your left hand.
Can't walk, having these subconscious tics. This is the CM. Okay, so this is right after surgery, drinking a cup of coffee. This is stimulation of the CM thalamus, central median thalamus. So very good results with. So some of our experience already published, deep brain stimulation for Tourette syndrome. This is also one of our strong interests, which we're working on. I think as the future smart DBS systems are evolving, wireless programming, you can do programming sitting here on a patient in China or in the US with some of the newer stuff which we are using now. So there's real-time detection of neurochemical You can see the wing system, which is a wireless instantaneous. Very soon we'll have removal of these wires, also the leads which are in between the stimulating, and we'll have chips placed into the brain outside. And I think this is where we are heading as the technology is moving. So some of the videos, I'm not going to bore you with that. Let's just programming. So now we have.
Bring both your hands together.
This was the first one we did on a wireless.
You can't see tremors in Paul Denison's hands now, but a decade ago, the outlook for this
we converted the first one into a
looked a lot different.
iPod
Mostly the right arm.
from a Medtronic to a different
Denison
company.
underwent what's called
So-
deep brain stimulation surgery. We first showed you the procedure 2 years ago on another patient at JFK Neuroscience Institute. Surgically implanted electrodes on the brain send impulses that block signals, causing tremors and involuntary movements. The 20-year-old procedure is wildly successful, with just one downfall. Patients were given a bulky remote-controlled generator to manage the system. It was tricky to use alone and required in-office appointments for adjustments.
This is Dr.
Until
Hanna, who's
now,
our
where
neurologist
brainwaves
in
meet
New Jersey
touchpad.
when I'm operating there with him.
From the older system to an iPod, where they can just remotely go up and down on their parameters, even at home.
So this is what we're
Denison is
using
the
very
first
freely in
patient the
Pakistan
US to
also,
marry
all
the old
remote
system to
programming.
new, managing
So
his
I think we
GPS
are
from an iPod Touch.
at par with
Specifically,
any Western country now, even in Pakistan.
Adjust
And
frequency, amplitude, pulse width. So there's some scientific electronic features that they can adjust to help their symptoms.
It's just so simple now. You know, you go to the App Store, you load the
you just need an app, right? So
and
to
it's
be
right
able
on
to
the screen,
program.
everything you need to know.
And that gives patients both flexibility and control. The results are instant. Patients can turn the system on or off, adjust settings, and anyone around them is none the wiser.
We can program the device with thousands of different settings. And we give the patients a certain parameter where they could do modest adjustments themselves. So it gives them some control and power over their condition in the sense that they can.
So this gives
make
us
some
an
fine-tuning and
overview
some
of the
adjustments
programming and
on their
how
own based on the symptoms.
It ain't a cure, but compared to some side effects of medications, I'd go with this.
You would.
Yes.
Medications often left patients with severe side effects. The iPod means back to life, back to work, back to friends.
From now on, I'm so grateful.
Okay, great. So this was what we were using initially also, but now, like I mentioned, we always get a CT or an MRI post-operatively. This is a CT just to look at that, so you can compare the preoperative versus post-operative. This is a very thin 1.5 millimeter, 2 millimeter CT, just to look at the tract as we. This is extremely important, not just to rule out hemorrhage, also to ensure placement, because that's what is going to dictate the future of this patient. So again, all these indications established and the future emerging. I think all of the people who are listening, they all have interest in functional, and we would strongly encourage them to be in touch with us. Come visit. Of course, we'll also come and visit Saudi Arabia also with Professor Ahmad. So with this, I would like to conclude. Thank you so much.
Thank you so much, sir, for the wonderful lecture, and it's a real honor for us to have you here, and also in Pakistan, because, sir, your presence is a huge, I think it's a huge benefit for not only us as residents and trainees in the matter of our much improved training level, but also for the patients, which is a big thing that you have, your presence was a source of huge benefit in providing much better health neurosurgical care to most of our patients, and for providing them with advanced neurosurgical procedures and everything that we couldn't even imagine to have before. Sir, I would like to here add one thing, that Professor Asif Bashir's father was a pioneer of neurosurgery in Pakistan. Professor Bashir Ahmad is also my mother's teacher from KMU. He's retired as a principal, but he was the person who actually pioneered neurosurgery in Pakistan. So it's a huge honor and it's a matter of great pleasure. I usually talk at home that his father was my mother's teacher during the medical college, and I was later during my training. I had the privilege of learning from Professor Asif Bashir as I completed my training from PIMS. But I think it's a huge thing that I we really appreciate, and thank you so much, sir. Your presence is a matter of huge achievement for PIMS and for Pakistan in general, because we are now able to introduce several, and we are as trainees we were able to see several new surgeries that we never had the privilege of seeing before. We now move on to our third speaker, Professor Dr. Anirban. I think he's here in the panel. Dr. Anirban Banerjee is the Associate Director of Neurosurgery at Vedanta Institute of Neurosciences. He's the Fellow of Functional Restorative Neurosurgery from Cleveland Clinic, and also Fellow of Skill-Based and Complex Vascular Neurosurgery. He will be talking about fiber tracking-based deep brain stimulation surgery for Parkinson's disease. Dr. Anirban, the floor is now yours.
Good afternoon, distinguished senior colleagues. And it's an honor to be on the same platform as Professor Alhani and Dr. Bashir. Dr. Noor, thanks for the opportunity. So I'm Dr. Banerjee. I'm a functional neurosurgeon in India. My training in this regard pertains to 2 years of clinical fellowship at Cleveland Clinic, USA with Dr. Ali Razai and Dr. Andre Machado's group. There's some issue with moving of the slides. Yeah, now it's fine. Are the slides moving?
No, we cannot see. Kindly share your screen.
Okay. Still not seen?
No, we cannot see it.
Now?
No. You have to hit the share screen button.
Yeah.
In the bottom, you can see the share screen button, and just move on with the PPT, with your PowerPoint. Yeah.
Now can you see?
Yeah, we can.
Right. So let me go to the.
Yeah, so the presentation mode is at the bottom.
Yeah. So is it moving? The slides are moving?
Yes, perfect.
Yes.
Yeah. So no conflict of interest, no funding. So April being the World Parkinson's Month, and now when I came back from my training, it's around 11, 12 years from Cleveland Clinic, started the functional neurosurgery program in eastern part of India. Now I'm in the capital, Delhi. What has plagued me in my experience, I'm sure with the experience of most functional neurosurgeon as well as movement disorder neurologists, is that there are certain symptoms in Parkinson's disease which are very tenacious. Whatever you do the best of medical management, you do a good surgery with conventional programming, repeated programming, but there are certain axial symptoms, especially freezing of gait, on-time freezing of gait, which doesn't get corrected by all those conventional things in DBS, what we do. Now, over the years, we have applied various corrective strategies, like looking for new anatomical targets, like the pedunculopontine nucleus for freezing of gait, hardware innovation in the form of directional leads, combined therapies, we combine DBS with spinal cord stimulator, and also we have done some fine tuning with the programming maneuvers, like specially use low frequency stimulation for patients who are suffering with these axial symptoms and freezing of gait. But none of them seems to have a sustainable effect. Now, it is common knowledge, and it has been covered in previous talks also, that DBS, the function, the mechanism of action of DBS is not limited to stimulation of static targets. It has an effect on the entire neural circuits of specific disease symptoms. Now, how to delineate those circuits? With conventional MRIs, it's not possible. So here comes the role of advanced MRI technology, for example, diffusion MR tractography methods, especially the DTI, the diffusion tensor imaging, which is very easy to use and it's set in most clinical practice MRIs, to delineate those white matter tracks. And instead of planning our DBS towards stimulating the static targets, it's very important that we direct that stimulation to those neural circuits or those white matter fibers where they're confluencing with these gray matter relay stations. Till now, unfortunately, there is a distinct paucity of relevant literature in this regard, and then our study was just an attempt to address this lacuna. So before going to the core of our topic, I'll just revise about the fundamentals of conventional anatomical targeting largely depends on the work of Alexander and DeLong in the late 80s. Subthalamic nucleus being the commonest site for stimulation in Parkinson's disease, not only because it caters to all the symptoms, there is a significant reduction in the medication requirement with time when we have a ST and DBS. GPI usually we prefer, at least I prefer in my clinical practice, in patients who have early onset L-DOPA induced dyskinesias. Even with small doses of levodopa, if they have significant dyskinesias, then GPI is a preferred target than STN. As far as WIM is concerned, it's anecdotal and obsolete in that sense. It's mainly used nowadays for non-Parkinsonian tremors. Now, within the subthalamic nucleus also, we need to target for a submillimetric accuracy. Excuse me, I think there is some voice coming in. Anyway, so within the subthalamic nucleus also, we need to target the dorsal, posterior, and lateral part of the subthalamic nucleus, which is the motor STN. The conventional methods include indirect targeting with the help of in relation to the ACPC. There are some standard values which come up, but the problem with the indirect methods are that, or the stereotactic atlas, is because they're based on very few limited brains, and the human anatomy varies significantly even from one individual to the other. So here comes the role of direct targeting with advanced MRIs, where you directly pinpoint your target, for example, in this case, STN, the motor ST, in relation to specific anatomical targets like the red nucleus. Usually we have to go 3 mm lateral to the confluence of the anterior and lateral margin of the red nucleus. It comes to the sweet spot of motor STN. Now for GPI, again, we target the posterior 1/3 of the GPI. We have to have special sequences in the form of inversion recovery or proton density sequences. Here's an example of one of my cases where early onset levodopa-induced dyskinesias. So we had to opt for GPI in these cases. And WIM, of course, is not of much use in Parkinsonian, but I use it mainly for non-Parkinson tremors. The point to make here is that both WIM, GPI, as well as the STN have got their own homunculus, and we need to do fine-tuning of the placement of the electrodes according to the body parts which are involved in individual patients. Now, coming back to the core topic, now, is there a need for a tractography in this DBS planning for Parkinson's disease, where most symptoms, motor symptoms, example, tremors, rigidity, bradykinesia, they are reasonably well controlled if you have a properly done DBS with good follow-up programming with an experienced neurologist. But there are certain symptoms which are intractable, especially the axial ones, the freezing of gait. So perhaps the final question of DBS for such symptoms is not settled. And over the years, especially over the last 7-8 years, there has been a consistent quest to understand that why those symptoms are intractable or resistant to conventional DBS stimulation. There was a landmark paper by Fling et al. In 2014 in this regard, where he pointed out that there is a consistent pattern of alteration of functional activity between the supplementary motor area and the STN in patients with predominant freezing of gait. So his was a functional MRI and the DTI combined study. And the same observation was made by Cow et al. Using a positron emission tomography study. The above two studies were validated by an animal study by Pan et al., where he found an affirmative effect of the pharmacological blockade of such a pathway connecting the supplementary motor area and STN in patients who have predominant freezing of gait, or in the animal subject. It was a rat study who had that freezing of gait, and they tend to respond much better when we stimulate or place the electrodes at that place of the STN where the fibers from the supplementary motor area are converging, rather than the conventional site of DBS stimulation of STN. These studies were further validated by clinical tractography studies, where they found that correlating the physiological effects of clinically effective DBS electrodes upon the afferent and efferent basal ganglionic, thalamic, and cortico-subcortical connections of the STN, they found that those electrodes which were in close proximity to a particular region of interest in the dorsolateral STN, the results in those patients pertaining to these axial symptoms of freezing of gait were much, much better than in control patients where we had placed the electrode following conventional DBS strategy. So this region of interest which was marked out was an area of amalgamation of certain corticofugal fibers emanating from the supplementary motor area and the ipsilateral motor cortex. And this particular circuit was marked the so-called hyperdirect pathway. Following this, there were certain clinical studies, some prospective, some retrospective, where they found that modulation of these white matter tracts in those patients were significantly associated with favorable outcomes in terms of freezing of gait and axial symptoms. So there was a series of studies. The most important one which came out in Brain in 2016 was by Aro Yave et al., followed by Avicilla, Chezin et al., Peterson et al., Chen et al., and the latest, it even runs into 2020 by Wesel et al. In all these studies, they found that wherever they have used tractography-aided stimulation of the fibers which connect the SMA and the primary motor cortex with the STN, rather than just stimulating the conventional motor STN, this freezing of gait and the axial symptoms were much more better in those patients. Now, these clinical studies were further supported by electrophysiological corroboration also. There were studies by Ospal et al. Where they found that the circuit which was marked out, the hyperdirect pathway, the local field potentials showed a lot of high beta frequencies. And when there was a suppression of those beta frequencies by neuromodulation, by DBS, there was an improvement in these axial symptoms of freezing of gait, both in off time and on time. We also had a similar study of 24 patients with a control of 12, where we followed, where we did the deep brain stimulation without DTI, diffusion tractography 8, and another 12 where we did it with diffusion tractography after taking permission from our institutional IRB. The strategy what we followed was we took first a high resolution diffusion weighted MRI sequence of the patient, usually ranging between 20 to 62 diffusion encoding directions. Then the motor STN was manually marked in the T2 spin echo MRI by the senior surgeon, that is me. And the SMA, the supplementary motor area and the primary cortex were demarcated on the 3D MP rate sequence. The above T2 and T1 weighted sequences were then co-registered, and the resultant sequence was further registered with the pre-processed diffusion weighted data. The DTI mathematical model, the tensor model, was then applied to this co-registered image between the two seat points, that is at one side the SMA and the primary motor cortex, the other side was the STN. And only those tracks culminating directly into the already mapped STN were secluded as the hyperdirect pathway. As you can see here, these are all the final co-registered images. These are the fibers which are coming from the SMA and the primary motor cortex, which are being which are amalgamating with the motor STN. You can see in these reconstructed images here. only that part of the STN, within that motor STN, where these fibers are amalgamating, the SMA and the primary motor cortex fibers were amalgamating, those were selected for stimulation, for placement of the electrodes, for targeting the electrodes in these patients who had predominant freezing of gait as a symptoms as compared to conventional resting tremor, rigidity, and bradykinesia. So once we had the final registration with the stereotactic images in our planning station of those DTI images, we got the values and proceeded with the DBS in a conventional manner, which has been covered by the previous two speakers. It was a 3-visit study of 3 months and 6 months apart. The main points of study were the United Parkinson Disease Rating Scale Part 3 UPDRS 3 score. There was an axial subscore and the freezing of gait questionnaire score with a stand walk sit test. The slide is a bit busy, but just consider on the final 2 columns. As you can see, at 6 months, patients who had with DTI DBS done, there was a significant improvement in the UPDRS-3 motor scores as compared to that cohort which didn't have DTI as part of the planning, especially the axial symptoms. However, there was no difference in the tremor scores. The freezing of gait scores were also much better in patients who had this DBS done with those DTI-aided tractography delineations. So the results were that compared without DTI cohort and with DTI cohort, there was significant reduction in freezing of gait in patients where we applied fiber tracking to do the DBS in those patients. Although they were not statistically significant because the numbers were not much, it was 12 each in each cohort. Another point which came up was there was no significant change in tremor outcome. That means irrespective of whether we were doing a conventional DBS or a fiber tracking DBS for STN in Parkinsonian tremor, it hardly matters. Conventional targeting itself yields excellent tremor control. So tractography for tremors are usually used for non-Parkinsonian tremors mainly, especially while targeting the WIM. Then a few examples of one from the study. This is a patient with significant axial symptoms and freezing of gait, with supermaxed medical management, significant unpredictability, motor fluctuations. But he was especially marred by even on-time freezing of gait, which was intractable to best of medical management and physiotherapy. This is the same patient 2 days after surgery in a medication off state. None of the medications are being employed. And there is a significant improvement in the freezing of gait and the axial symptoms. This is one of my patients from Bangladesh. Another example, patient from Himachal Pradesh. So I picked up only those patients who had significant walking difficulty due to axial symptoms and freezing of gait, including on-time freezing of gait. A little bit dependent on their caregivers. This is again day before discharge, medication off state. So conclusion, tractography aided deep brain stimulation surgery can be used to modulate the hyperdialectic corticosubthalamic pathway so as to enhance its efficacy with regard to certain difficult to improve axial symptoms and freezing of gait in refractory Parkinson's. Although the trends are promising, refinements and standardization in tractography techniques, as well as stronger levels of evidences pertaining to relevant translational research are warranted so as to further validate these initial observations. So these are just initial observations. It's an attempt to find answers to those symptoms of Parkinson's which usually don't get controlled by conventional methods of neuromodulation, whether it's deep brain stimulation or lesioning. This is my overall experience of 215 deep brain stimulation cases in Parkinson's disease over the last 12 years. If we include other indications, it's close to 300, and with results are quite as comparable to that in literature in terms of both improvement in the symptoms, maximum in resting tremor, and also significant improvement in rigidity and bradykinesia, and around 70 to 80% reduction in medications by 1 year of post-DBS therapy. There's a question here. Thank you.
Thank you so much, Dr. Anirban, for the wonderful talk and for all the wonderful points that you have shared. It is really important to just discuss these wonderful points with us. There is another words I want to add in keeping with all the recent advances and everything in neurosurgery. Neurosurgery is a really dynamic field, and every day there is something new that we can just discuss and we can integrate in our new practice. So there is another word that I would like to share here. तू रह नवर्द शौक है मंजिल न कर कबूल लहला भी हम नशी हो तब महमिल न कर कबूल. That means that if you traverse the road of some passion, do not yearn to seek rest or get distracted by any temptation, because it is a constant journey. So neurosurgery is very applicable to on neurosurgery. It's a constant journey. We have to struggle a lot and learn and improve ourselves as much as possible to be in the field and to be in the leadership and to provide the best possible care to our patients. So thank you so much for the amazing talk that you have delivered, and obviously you have a wonderful experience with robotic neurosurgery as well. So I think that next time we will certainly like to invite you to deliver a lecture on robotic neurosurgery. We have another webinar in line for robotic surgery. So again, thank you so much. First of all, I would like to thank Professor Ahmad Alhani for being here, and Dr. Anirban. Again, thank you so much for sharing your amazing lecture. I think everyone who is right now here will be very pleased. Professor Asif Bashir had to go to operate a patient. He had an OT day today, so he's one of my mentors. I'm really pleased. It was an honor to have him here and to have him share the knowledge and to share the experience we are having in DBS in Pakistan right now, which has DBS is recently being introduced by Professor Asif Bashir along with Professor Khalid Mahmood in our center in Pakistan, in Lahore, particularly at PINS, from where I'm affiliated with which I'm there. So again, sir, I think there is one question here in the Q&A. What kind of complications have you got during your experience in peroperative situations? If yes, how did you handle these? Other question, what do you suggest to the anesthetist after the procedure?
This is directed to whom, the question?
I think this was, can you please, I think this was for Professor Asif Bashir, but I think that Professor Alhani, I think you can answer this question very well because you had a wonderful talk.
Thank you very much. It is an easy question. Well, it's not easy. What kind of complications?
For you, sir. For you, obviously. Yes.
No problem. So in the perioperative period is few issues. Number one, we always worried about bleeding during the surgery. We always worried about bleeding during the surgery, because you introduce the electrode, you implant in the correct place, but you are worried that you may have a problem with hemorrhage. And I showed one of the slides in someone who had a venous infarct after injuring one of the cortical veins. We have not seen bleeding from the basal ganglia, although it can happen. But this is one of the most important adverse effects that we are worried about. So how to do that? We want to make sure that the patient does not receive any medication that help the bleeds, like aspirin, most important. Sometimes non-steroidal anti-inflammatory like Advil for headache also has some aspirin component and may act as a platelet inhibitor. Of course, controlling blood pressure, and this is the second part of the question about the anesthetist. We always like the blood pressure to be in a very controlled mood during the procedure, not in the low or in the high, but rather in the normotensive zone. So extremely important to communicate with the anesthetist to make 100% sure that the patient blood pressure is well controlled. Now, we are worried later on after surgery to have infection from the hardware. Well, we have not seen that much in the post-operative period, immediate post-operative period, but later on with the battery itself, as I showed in one of the photos, the skin may be very thin and the patient may have more than one surgery to replace the battery. And this may lead to breakage of the skin, and this will lead to contamination of the batteries and infection that required removal of the hardware, allowing things to settle, then to re-implant it again. So you want to divide the complications into complication related to insertion of the deep brain stimulation, complication related to the maintenance with the hardware. On the other side, complication related to the stimulation itself. The beauty about complication with the stimulation itself that you can stop it only by closing the stimulation, but that means the patient did not benefit from the surgical intervention. And here, directional lead and good programming can reach with you to the best improvement and avoid complication from the stimulation itself. Migration of the lead do happen sometime, but we readjust it on the same pathway. So overall, for example, in our program, yet to have a mortality, we are not looking for a mortality, but we do not have a mortality from our deep brain stimulation, but we do have 2 or 3 serious complications, and eventually all of them improve slowly with time, not counting on the infections, late infection or breakage of the hardware later on, because this is something we see it. We see it, at least we have replaced 10 or 15 patients who had a problem with their hardware in terms of skin breakage, in terms of infection, in terms of cut in the wires. That does happen, not infrequent. Now with the new generation of hardware, we hope that these complications are going to get less and less with time. I hope I answered the questions.
So thank you so much, sir. You have very elaborately answered the query, I guess. So I think that addresses all the things that he might have asked. I don't think that there is any other question, sir. Again, sir, thank you so much for the wonderful talk. I think it was so much comprehensive that everyone had a very good picture of the whole procedure, and we were actually left intrigued with everything that you have mentioned, sir. So nicely elaborated, sir. He has sent you a big thanks. This is Ibrahima Suri. She sent you a big thanks. Thank you, Professor, for the answer, because we have some complications like bleeding after the first step implantation, and finally we plan the operation for the next step. So thank you so much, sir. I think that there are patients nowadays with the NOACs and DOACs, the neuro and oral anticoagulants. So they usually, while we are actually still following those precautions, but still, and there's an absence of much literature. But do you think, sir, these NOACs and DOACs can have any better profile regarding coagulation profiles dealing with our patients operatively, not only in DBS but otherwise, because they think that NOACs are much better regarding any bleeding profile as compared to the classical anticoagulation and etc.
I'm not sure I understood the question very well, but we are very critical about coagulation profile. Patients who need anticoagulants, we do not operate on them. Patients who has, for example, high risk of PE, having atrial fibrillation, previous stroke, we do not usually put them high in there as a candidate for surgical intervention. Now, later on, if the patient developed a problem that require anticoagulation, we usually have no problem with that. If the patient already had the surgery done, and like 2 weeks later on, 2 months later on, he developed whatever pulmonary embolism and he needs to be on anticoagulant, we usually do start with precautions for the level of the INR, for example, but we have not seen a problem with anticoagulants per se. If the patient already on anticoagulants pre-op and he requires this for significant reason and not on a prophylactic base, we usually don't like to select this patient for surgical intervention.
Thank you so much, sir. This is a wonderful session with you, sir. And thank you so much, Dr. Anirban, for coming up as well for the amazing talk that we had. Sir, I do think that we had a wonderful feedback regarding the lecture, and everyone is really asking for the recording now. So I think that, sir, again, huge thanks. And I think it's time for us to wrap up the session. Again, thank you so much to both of you for allocating some of your very precious time today for this session, and for sharing all the knowledge that is totally priceless thing to do. It's totally a treasure for all the neurosurgical trainees who will keep on listening to all these talks, the wonderful talks through the recording that will be available on YouTube after the program. So again, a huge thanks to you. And I don't think that we have more questions right now. So I think we can wrap up the talk.
Oh, excuse me, Noah, there is one question. Abraham has another question. Do you see it in the chat?
No, I think she had one question.
Yeah, Abraham, do you want to ask the question directly, Abraham?
Thank you, Professor John, and thank you for the best presentation. Professor Ahmed have already answered my question. That is quite a huge complication we have recently have in our department. So usually in with the anesthetist with no proper experience with the Parkinson disease patient. So it's quite very difficult to handle that kind of complication during the operation, because we was wondering how to do. We're gonna like take out the stimulation because the patient was having a blood from the gangliobasal. We do the CT scan and we follow up for a few days. After like 1 week, the patient finally recovered well. No other complication more than the blood. So we observe, and finally we decide in staff to put back the second step of the Parkinson disease operation. So that happened to us. That I was wondering if they have any idea how to handle that kind of complication. Thank you, Professor.
Thank you.
Thank you so much, sir. Thank you so much, sir, again. And thank you so much, sir, for addressing all these queries and everything. And I think that it is time for us to wrap up the session. Ramadan Kareem, sir, to you as well.
Ramadan Kareem.
Is there any question? Is there any question or queries still there?
I just want to say thank you to everyone. Thank you for you, Noor. Thank you for John for the technical support. It's an excellent channel on YouTube, and I do benefit a lot from it, and I do encourage all our residents to benefit from it. It's free, available, good quality. Thank you again. See you later.
Thank you everyone.
You know, Ahmed, Nora put this together, and I appreciate all her efforts. You know, it seems, I'm not a neurosurgeon, I'm a regular doctor, but it seems to me like it's a no-brainer. I mean, why not get the DBS? Why isn't it more penetrated into the community? Is it a lack of money that the people can't do it, or what's the reason why there's not more of it?
Well, that's a good question. It's not only money. Yeah. The surgery has a risk, has a margin of risk. Yeah. And you will be with deep brain stimulation for the rest of your life. Right. So there is a price to pay, not in dollars, but in life. Okay. In carrying risk and in being limited to what you can do and what you cannot do. So unless the outcome is worth it, then we should not just put DBS on everyone walking in the street. So unless the benefit is substantially more than the risk and the life, then surgery should be directed only to the patient who really in needs of it.
Oh, okay. Okay.
And if I may add to this, there is a definite lack of awareness also. And that's the purpose of these webinars, especially in the month of April, it's a Parkinson's Awareness Month. The more the message reaches out to the masses, the more compliance will increase towards this therapy, because this is really a therapy for patients who are backs are to the wall. Nothing works for them. And it makes a dramatic improvement in their quality of life. Although, as we discussed, we are still short of having the 100% answer. Some symptoms are still quite intractable, but it still makes a lot of difference in majority of such advanced Parkinson's patients.
Exactly, and like Sir has very well, very nicely said that patient counseling and preparation is also very, very much important. That how the patient actually sees it. So it's really important that how they, what they are expecting from their surgery, and how their attendants are considering it. So we have to be really clear about it, because sometimes patients really do think that they have higher expectation that there will be a cure, because from surgery people think that it's like taking out something and they will have it back totally to normal. So this is another sad point, and the mindset of the patient is obviously very, very important. But another point here is that not everyone is that much well trained to perform this surgery as well. In Pakistan, I can tell you that we do not have so many DBS surgeons, so there's a level of training that is required to perform this specific training, and to have any opportunity to do a fellowship in functional neurosurgery and everything, and obviously a higher level of training that is required. So we do not have that many people trained for the DBS surgery in Pakistan as well. So we said these are several reasons why it's not that much widely available and in our countries. And obviously people are not quite ready to get operated, even if you tell them that they might require it. So they consider it obviously that it's going to be a brain surgery. So it's a huge thing for them.
Okay, Ibrahim, where are you from?
I'm from Guinea Conakry. I'm actually doing my training in China, in Shanghai, in Huashan Hospital. Wait.
Oh wow! Is that where Dr.